Welcome to the Scale Community Analyzing Healthcare podcast. We're joined by Kyle Zebley and Ann Mond Johnson. Ann and Kyle represent the ATA, American Telemedicine Association, Ann being the CEO. And
Kyle is Senior Vice President for Public Policy of the ATA and also Executive Director of ATA Action.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level. So let's assume CMS is fully on board. I'm surprised that it's taken them a while to be fully on board. That I know the CMS leaders, the folks in charge, going back 10, give or take years, their focus has been on continuous care, preventative care, monitoring outcome. These are the foundations of Medicare Shared Savings, of Medicare Advantage, the ACO program that was built, CMMI. These are their core themes. You would think that with that, a heavy push through incentives, better reimbursements, with an underpinning of digital care being a primary driver of these outcomes, would have been a core theme. Like, you wouldn't have needed to convince them. They would have already been on the case, driving reimbursements. Let's get back to that topic in a second. Put that aside. What is it at these state levels that existed before COVID and now once again is reinstated, that is at a very practical level, that is impeding operators from building great digital businesses across the country? And you say they've gone back. I'm aware of many digital care companies that have grown very happily over the last 5 years since COVID. They have used the wind in industry sales, and they've gone from local to national seemingly overnight. They've achieved scale. So I feel like this period of rapid digital growth is happening. And happening now over the last 5 years versus before. Wasn't really common to see that in 2015. Part of that is the technology wasn't there, the costs were too high, but part of it was this state variance. But when you say they've gone back to their old ways of doing business, these states, is it the variance? Is it the fact that every one of them has their own rules regarding how much care can be provided virtually versus direct supervision? Is it the accreditation requirements and they slow you down? What is it they've gone back to that's once again a significant impediment?
Well, just to not let go unanswered real quick, the CMS was very supportive, continues to be very supportive of telehealth, digital health.
But why not? Then why not have Medicare pay you well? Why do I hear complaints? And I'll speak to these folk. I'll ask them the same question. The Liz Fowlers of this world, and the Minas and the Seamers. Why did I ever hear complaints about telehealth? Well, it's great, but we can't afford to do it because it's just the reimbursements are so poor. Where did that come from?
Well, before you even get to questions of reimbursement, you were never going to have any access to it because of law that was passed in 1997, still in place in 2020. That law had to be waived and continues to be waived by Congress, working with first the Trump administration, then Biden, now Trump again. So CMS has yet tremendous regulatory authority to expand access to virtual care services. They have. They've done that in concert with us. We praise them for it. But they're really impeded by lack of permanency from Congress in terms of what's in statute. When you come to
So that affects the available budget. So they're supportive,
Well,
but they don't necessarily have the funding.
That affected their ability to cover it at all, period. The even more fundamental question of can they even reimburse it regardless of what the rate of reimbursement is. They have been reimbursing telehealth at a higher rate, an outpatient rate of reimbursement. And they have done that now for 5.5 years based on their sole regulatory authority. They haven't been forced to do it by Congress. I'm not saying that reimbursement is probably ever enough for many folks, and I'm not dismissing.
I'm just looking for parity.
Yeah, and that's what they're getting. That's what they're getting at this higher rate of outpatient level reimbursement. I think you will see concerns and complaints from folks, very well-meaning folks from across the board, about levels of reimbursement in our healthcare system, be it Medicare or the much lower reimbursed Medicaid rates. They're still a fraction of what about 80% of what commercial insurance pays. That's true across the board, whether or not you're talking about telehealth or not. But I think if you don't even get to
that's neither here nor there. Everyone faces that.
Yeah. So I think we're just talking about ever expanding levels of coverage and reimbursement. We want to move towards a value-based payment system for all types of payers, because that's, I think, what will fully capture the value of telehealth when you're not doing everything fee for service and you're moving away from that mindset. That's going to be years, if not more, decades to come. And that's something that obviously we've got to continue to play in this fee for service world. And I think we do a very good job of it. But I just want to put that on the table. To answer your question on the state level, just real quickly.
Before you go there, and I'm thrilled that you remember that.
Yeah.
I'd love to hear the answer to that. This law, this 1997 law,
Yes.
Give me some more color on it. That sounds awful.
Yeah, it was included in the Balanced Budget Act of 1997, and it was actually...
We're going back to Newt Gingrich days.
That's right, and a deal worked out with the Clinton White House, and it actually was. It's a classic example of a law that's fixed in stone that was beneficial at the time because it was the first ability to cover telehealth at all in the Medicare program that ended up being an albatross around the neck of our community come 2020 because Congress wasn't doing its appropriate job of either having a flexible law that responds to the time or updating laws. But choose one or the other. They chose the worst option, which is just leave it in place. But what that 1997 law said was if you were in a geographic rural area, if your originating site was a provider's office, you would have access to some reimbursable telehealth services. That's what was about technologically imaginable with all the technology required in 1997 to deliver effective telehealth services. But by 2020, in the advent of the iPhone, which had come 13 years previously, that 1997 law had become long outdated. It hadn't kept up with technology and it had become a burden for us. Those geographic and originating site requirements have been waived ever since the onset of the pandemic. Still not permanent, actually set to expire at the end of this month, barring congressional action. And frankly speaking, despite our broad-based bipartisan support that has spanned multiple administrations of both parties, we're working against, frankly speaking, congressional dysfunction that has put us in this situation.
So let me regurgitate that back to you,
please.
And I'm gonna purposely describe it in ways that sound dramatized, borderline shocking. But that's what I'm seeing here. So please correct my misunderstanding. The only reason why digital health in all its facets is being widely adopted in the US is because since 1997, despite a law that limits digital health to just rural settings, we've managed to function under an exception that every once in a while faces an expiring date. Is that right?
Well, just for Medicare fee-for-service. And there have been other reasons, probably more of culture and habit than otherwise, that we hadn't seen robust adoption of telehealth technology in a lot of ways prior to that. But Medicare fee-for-service is still the number one driver of change for payers in the country. They still cover the most beneficiaries, and if they cover it, almost every payer tends to look at that as a floor, a bare minimum of what must be covered. It was a tremendous hindrance to us, but to be fair, there are other reasons. Each Medicaid agency at the state level really goes and determines for itself, based on the whims of the state legislature, what's going to be covered. And commercial insurance is looking to hold down costs in general, and so they were, I think, pretty reluctant to offer.
No, there are other contributors, no doubt. I just want to get your nod of approval that this one is as I described it. This law,
it was 1997,
is truly the albatross that I'm describing.
Yes, that still rears its ugly head every time we get close to the end and expiration of these flexibilities. And we've only got about 26 days as of today that left of these Medicare.
Let's assume the exception does expire in 26 days. What happens the following Monday? You've got millions of encounters of digital health happening in non-rural settings. Are they illegal?
For Medicare fee-for-service, yes. And that will have a lingering impact that will ripple for months up to about a year and a half before it is devastating to our community. But most immediately, the day after, every Medicare beneficiary that is a fee-for-service beneficiary, so about 50% of the total Medicare, or over 65 age population in the United States, they will have had access the day before, and they will lack access. About 99.9% of them will lose access. And it's not to say that the providers can't offer it, It's just that they won't get reimbursed. It will be devastating. It will be crippling. It will not be allowed to stand, because this is every state. This is every congressional district. This is every region of the country. These are very active folks. We're fighting on their behalf, whether they know it or not, to make sure that they don't lose that access. And this is all despite the fact that
this is just a reimbursement issue, which is meaningful enough. I would think this is also a compliance issue. Well, you would become non-Medicare compliant at that point.
That's you would be doing it as charity, or you'd be doing it with the expectation that you'll get reimbursed down the line. It's what is allowable from a reimbursable basis, from our perspective.
It sounds.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.